Tokyolive
Endoscopy
Endoscopy
1.
So hello everyone, welcome to this session. Session title is a new cutting edge tool for screening endoscopy. So last year, Olympus released the new processor X1. That is a combined new processor which covers both the 100 series and the 200 series. So of course in Japan, the used to be a 200 series. So no difference, but in the outside Japan and particularly US and the Europe, the mostly 100 series. So sometimes it made some confusion to make a precise evaluation of the, for example, NVI magnification or some other. So, but now we can definitely we can use the both equipment in the same platform. So that is the X1. It's a great one. So also Olympus released the 1200N. That is a pediatric scope. So I mean small caliber scope for any part of the GI tract. So today we have two distinguished speakers to demonstrate or talk about this new scope. So I would like to introduce the first speaker. So first speaker is Dr. Akira Dobashi. So he spent 2 years in a Mayo Clinic, and then he came back from Mayo to JK University. Now he's an assistant professor of JK University or School of Medicine. So Dr. Dobashi, please start your lecture.
Thank you very much for giving me to introduce me kindly. So I'm Akira Dobashi at JK University. Today it's a great honor for me to give a lecture at Tokyolive. I'd like to send my sincere gratitude to Dr. Inoue for this kind invitation. So I will start my lecture. Today, I'd like to discuss advantages of high definition ultrasound endoscopy in upper GI cancer screening endoscopy. Those are today's topics. I believe Dr. Suzuki will show the objective data on gastric cancer. So I'd like to show mainly the diagnostic performance of the outer slim endoscope for superficial pharyngeal and esophageal cancer. By the way, what do you think is essential for upper GI endoscopy? I think less invasive endoscopy and reduction of overlooked cancer are essential. So whenever I perform endoscopy, I keep in mind those points to maintain high-quality endoscopy. Sedated endoscopy is preferable not only for patients, but also for endoscopists. Patients can undergo endoscopy with reduction of anxiety, stress, and discomfort. On the other hand, endoscopists can perform endoscopy with improvement of quality of endoscopy and endoscopist satisfaction. However, sedated endoscopy causes some adverse events, such as respiratory depression, hypotensive action, bradycardia, and so on. Mortality is extremely rare, but it can happen. Therefore, we should need critical care and monitoring during and after examination, with some nurses for safety. So it may be challenging to provide endoscopy for many patients in a day in a single hospital. I will show you pictures of endoscopic room and recovery room at the JK Hospital. We renewed our endoscopic rooms a year ago. All patients, including outpatients, undergo sedated endoscopy at the GK Hospital to satisfy both patients and endoscopists. We have 10 separated endoscopic rooms and 18 recovery beds. Each bed has a monitoring system with ECG, SpO2, and blood pressure. Accelerated endoscopy has advantages, but it needs equipment maintenance and many nurses to monitor the patients during and after the procedure. Unsedated endoscopy is well performed for outpatient in Japan to overcome this situation, and transnasal endoscopy becomes an option. Furthermore, it reported that transnasal endoscopy provided minor discomfort and tolerated endoscopy compared to paraoral endoscopy for unsedated patients. However, there was an issue with outsourcing endoscope concerning the image quality. In my experience, the image of alternating endoscope was darker and the resolution is not enough. So if I receive a screening endoscopy without sedation, I will choose paraoral endoscopy with a high resolution endoscope because I'm worried about overall cancer. We have a population-based screening system for gastric cancer in Japan. The target is over 50 years old. They can undergo endoscopy or barium X-ray examination every 2 years, covered by public expense. Unfortunately, sedated endoscopy is not allowed. Until recently, some endoscopists might think it was unavoidable to overlook tiny cancer when a patient underwent transnasal endoscopy. However, we should solve this issue, and we should provide less invasive and high-quality endoscopy. NBI is one of the solutions to improve esophageal cancer detection, and some studies showed outsourcing endoscopy with NBI improved the detection rate of esophageal cancer. We performed a randomized control trial with outsourcing endoscopy and high-definition endoscopy to detect gastric cancer more than 10 years ago. The study revealed that the missing rate of gastric cancer at the fornix and corpse for outsourcing endoscopy was significantly higher than for high-definition endoscopy. This result could indicate the image of outsourcing endoscopy was darker and lower resolution. After that, as the generation of endoscopes progresses, the image have improved, and the report showed the adequate diagnostic performance of outsourcing endoscopy for gastric cancer. Last year, a high-definition ultra-slim endoscope was launched. When I used this endoscope, I was impressed by the high-quality images. Simply speaking, the image quality is equal to conventional high-definition endoscopy. The images are brighter, noises are lower, and the resolutions are higher. Today, I will show you some cases of gastric cancer and how the lesion looks with ultra-slim endoscopy. Under white light imaging, you can easily detect an elevated lesion even from a distance. This was a challenging location to detect gastric cancer with former generation transnasal endoscopy. Under NBI, you can clearly identify the demarcated line and mucosal pattern as well. The histology from ESD showed well-differentiated adenocarcinoma. The other patients underwent endoscopy with the ultra-slim endoscopy for surveillance after ESD for gastric cancer. Helicobacter pylori have already been eradicated in this patient. A slightly depressed lesion with reddish color was found at the lower posterior body in the stomach. Under NBI, inside the well-demarcated depressed area, regular mucosal pattern was seen. When the lesion was inspected by magnifying endoscopy. Irregular microvessels were seen, and we could evaluate the lesion as cancer according to the VS classification system. With ultrasonic endoscopy, you can easily detect such kinds of lesions and take a biopsy in patients even after eradicating Helicobacter pylori. That's because the improvement of image quality. So let's move to next topic. The new endoscopy system has a function called BIMAC, which makes the endoscopic image brighter. So it is possible to observe whole stomach and NBI with BIMAC on. I prefer to perform a screening endoscopy in the entire stomach and NBI for patients with atrophic gastritis. You can detect a lesion even from a distance on the NBI. We can make the most of the ultrasonic endoscopy when combined with the new endoscopy system, EVIS-X1. Those images were taken by the same ultrasonic endoscope and different endoscopy systems. We can perform endoscopy with the larger monitor, and the improvement of image quality is obvious. So I will recommend the ultrasonic endoscopy should be used with EVIS-X1 system. So if we use the system and endoscope, you can find a tiny lesion like this. I showed some images before, and there was also the other lesion at the greater curvature here. It was really challenging to find the lesion, even though I used a magnifying endoscopy. This flat lesion was histologically diagnosed as a moderate adenoma. Like this, the ultrasonic endoscopy possesses high performance for detecting gastric adenoma or early-stage gastric cancer. So I moved to esophageal cancer. Under the NBI, superficial esophageal cancer was identified usually as a brownish area. Because of the high definition of ultrasonic endoscopy, you can evaluate microvessels as well without magnification. With this ultrasonic endoscopy, you can detect not only squamous cell carcinoma, but also high-grade intraepithelial neoplasia. The higher specificity for esophageal neoplasia is an advantage of NBI compared to lower chroma endoscopy. You might not be able to detect the lesions without NBI. Another advantage of ultrasonic endoscopy is the easiness of maneuver in the pharynx. We can easily forward the endoscope into the base of tongue or piriform sinus, even for unsedated patients. Squamous cell carcinoma at right piriform sinus was observed by conventional high-definition endoscopy and ultrasonic endoscopy. Can you identify which image was taken by ultrasonic endoscopy? The answer is an image on the right side. When the endoscope got closer to the lesion and the electronic zoom magnification function was used, I think you can easily assess microvessels. So I will move the last topic. We conducted a retrospective study to show a diagnostic performance of ultrasonic endoscopy for superficial cancer in the pharynx and esophagus. The current study uses 16 cases of superficial squamous cell carcinoma suspicious lesions. First, endoscopy was performed both by ultrasonic endoscopy and magnifying endoscopy for each lesion. Then, we selected the endoscopic image acquired by the ultrasonic endoscope and magnifying endoscope under NBI.
According to Japan Esophageal Society classification, the near image by the ultrasonic endoscope and magnifying image by magnifying endoscopy were evaluated as cancer or non-cancer by 2 expert endoscopists. 11 of 16 lesions were squamous cell carcinoma or high-grade intraepithelial neoplasia, and the others were non-cancerous lesions. The median size was 12 millimeters, and 9 of 16 lesions showed complete flat type. This table showed the result. The accuracy of ultrasonic endoscope was more than 80%, and the diagnostic performance of the ultrasonic endoscope was sufficient. The kappa value of the inter-observer agreement for the diagnosis between the ultrasonic endoscopy and high-definition magnified endoscopy was 0.63. So the ultrasonic endoscopy can be a reliable tool for diagnosing squamous cell carcinoma in the pharynx or esophagus. Right now, if I am asked, when you receive a screening endoscopy without sedation, what kind of endoscopy do you choose? I will answer like this: a high-definition ultrasonic endoscope with the new endoscopy system. Those are my conclusions. The ultrasonic endoscope can provide a less invasive and high-quality examination. The ultrasonic endoscope can become the first choice in upper GI cancer screening endoscopy without sedation. Thank you for your kind attention.
So thank you very much, Dobashi Sensei, for your great lecture. It's amazing image. Actually, Dobashi Sensei presented 1200 and a new scope image is actually better than 290 zoom image. I would like to confirm the several things to Dobashi Sensei. So in this using this new scope, do you recommend transnasal endoscopy or transoral endoscopy?
Thank you very much for your great question. I think that we can perform both transnasal and transoral as well. Unfortunately, JK University doesn't perform the transnasal endoscopy. I always use this endoscope. I perform endoscope with per-oral endoscopy. But the transnasal endoscopy is also very acceptable for the reduction of the anxiety. So in my expression, we can use the both oral and transnasal endoscopy as well.
Okay, thank you very much, Dobashi Sensei. And my additional question is, you recommend now you prefer to do per-oral endoscopy. So at the time, so do you recommend some sedation or without sedation?
So the merit of this endoscope is that we can perform the screening endoscopy without sedation. So I recommend to use this endoscope without sedation for the people for the cancer screening. So if we use this endoscope with the sedation, we can perform many cases per day in a single hospital. So it's very this is the advantages of endoscope.
Yeah. Definitely, we don't need a recovery room. So let's use a recovery room. So we have more capacity to complete the endoscopic examination. And then, so my second question is, so in your presentation, the NDI magnifying image was so good, so nice. So do you think you can evaluate, for example, squamous cell carcinoma? So esophageal society classification B1, B2, B3 vessel, just using the 1200 N. So that, of course, that has no magnifying so lever, no no lever, but the without using magnification, just close up to the target. Can you make a diagnosis precisely?
Oh, thank you very much. It's a great important question. Some of the lesions can easily evaluate the irregular vessels, so we can identify the type B vessels. However, there's, for example, the high-grade intraepithelial neoplasm or low-grade intraepithelial, it's really challenging to evaluate the microvessels precisely. But as I said, in a screening endoscopy, we can easily select the region which have to be taken biopsy. So in a screening system, there is not so many high risk patients for esophageal cancer. So it is we can perform the endoscopy for the alternating endoscope only. However, if you perform the patient for the high risk patients, such as the post ESD, post ESD for the esophageal cancer, it's challenging to detect a tiny lesion.
Okay. So thank you very much, Dova Sensei. You are a great talk. And let's move on to the next speaker. We will have a discussion all together later. So we would like to move on to the next speaker. I would like to introduce the second distinguished faculty. He is Dr. Sho Suzuki. So he graduated from Yamagata University. And then now he's working at the Nihon University, School of Medicine and the Division of Gastroenterology and Hepatology. He is assistant professor. Dr. Suzuki, so please start your lecture.
Thank you, Professor Inoue, for kind introduction. It is my great pleasure to have opportunity with the presentation in this Tokyolive 2021. Now I am sharing my slide. Hello everyone, I'm Sho Suzuki from Nihon University, Tokyo, Japan. Today, I'd like to talk about our experience with using new ultrasound endoscope, GIF 1200N, and its diagnostic performance for early gastric cancer. Here are the topics of my presentation. First, I will show the issues in the screening EGD and conventional ultrasound endoscope. Next, about the future of the new ultrasound endoscope. I will show the experience and the actual cases using this new ultrasound scopes. And finally, I will show the significance of this new scope for diagnosing the early gastric cancer. First, the issues in the screening EGD and conventional scopes. The screening EGD is commonly performed in the many regions, especially in the region with high incidence of gastric cancer, such as Korea, China, and Japan. In such countries, the screening EGD has been proven to reduce gastric cancer mortality. However, as Dr. Dobashi already showed, the EGD has some drawbacks. If using the EGD without sedation, the patient has low tolerance and discomfort during the EGD. On the other hand, if using the sedation, the risk of the adverse cardiorespiratory events may increase, especially in the elderly patient, and procedure time and the cost may rise. To improve the patient tolerance during the EGD, using ultrasound endoscope and transnasal route endoscopy are proposed. Here the photographic image of the both standard oral endoscope and the ultrasound endoscope. The ultrasound endoscope is generally defined as less than 6 mm in size of the scope tips. So that means that this scope is about half size of the standard oral scopes. So Because of the ultrasound size, ultra-thin size of the scope tips, the using ultrasound endoscope may improve the patient tolerance during the EGD and not only the transnasal route endoscopy, but also transoral standard endoscopy. So using the ultrasound endoscope, the patient is very comfortable and tolerable during the EGD, so EGD can be done without sedation. But ultrasound endoscope has some disadvantages, so the physician is annoyed with using the ultrasound scope. The critical disadvantages of the conventional ultrasound scope is poor image quality and extreme flexibility of the scope body. So some physicians dislike using the ultrasound scope for EGDs. To overcome such a disadvantage of the conventional scope, new ultrasound endoscope GIF 1200 was launched in Japan last year. The advantage and improvements of the new scope is first, high definition, HD quality image with minimal noise. And second, refined endoscopy stiffness and flexibility. So this new ultrasound scope may overcome such disadvantages of the conventional slim scopes. Here is the specification of the latest current upper GI endoscopes. The new ultrasound scope 1200 and has new CMOS event sensor, which is higher sensitive than the conventional CCD sensor. And the scope has HD, high definition image qualities, which is the same as the standard per-oral high vision endoscopes, H290. The high definition HD image provide the finer and the detailed image qualities compared to the standard definition SD images. So the new HD SIM scope may provide a higher diagnostic performance for GI neoplasms comparing to the SD images. Conventional SIM endoscope XP290N. I will show the endoscopic video images using the new HD SIM scope and the conventional SD SIM scopes. You can compare the image qualities between the two endoscopes. First, I will show the conventional SIM scopes. Of course, the conventional SIM scope provides enough image quality, but the distant part, the gastric fornix and the antrum is a little bit dark. You can see the small early gastric cancer regions at posterior wall of the stomach, but that is a little bit unclear and low contrasted to the surrounding mucosa. In new HD SIM endoscope, the distant part gastric fornix is brighter than the conventional scopes. The wall viewing the endoscopic images are bright. So such a very flat and small cancerous region is clearly shown with brighter and high contrasted image to surrounding mucosa. So we can easily find the regions. Here are the comparative images between using the new scope and the conventional SD scopes. In US HD SIM endoscope, the distant part, gastric fornix, is brighter than the conventional SD scopes. And the mucosal irregularity and changing the color tone due to gastritis is more clearly shown. So such a very fat and small cancerous regions can be clearly shown with the bright for imaging the bright and high contrasted to the surrounding mucosa. As you showed, the new HD SIM endoscope provide the bright and clear images, but it is just our impressions. So we evaluate the brightness and color contrast in the endoscopic image with gastric cancers examined by the two endoscopes. We used the LAB color difference scales for this evaluation. The LAB color difference scale is the 3D measurements determined by the color brightness and the green and red color tone and the blue and yellow color tone. We measured the LAB color scale inside of the cancerous regions, which is the red color area, and the surrounding mucosa, which is the blue color areas. The color difference of the delta E value was calculated based on the difference of the two areas. And finally, the delta E value color difference scale was compared between the new HD and the conventional SD endoscopes in 15 gastric cancer images. In the result, the delta E values the color difference between the inside of the cancer and outside of the cancer regions was significantly higher in the new HD zoom endoscope than conventional SD zoom scopes. In each element of the LAB, the elements of the L, delta L was significantly different. It is significantly higher in the new HD zoom scope than conventional SD scope. The elements of the L, delta L means the brightness of the images. So the new HD zoom scope may provide a higher color contrast with the higher brightness in gastric cancer images. Next, I will show the significance of the new HD zoom endoscope for diagnosing early gastric cancer. I will show the endoscopy video images diagnosing gastric cancer using the new HD and the conventional SD zoom endoscope. First, I will show the SD zoom scopes. You can see the mucosal irregularities at the rest curvature of the gastric anthers. Such findings, the mucosal irregularities suggest that is a neoplastic regions, early gastric cancers, but the border and the area of the gastric region is unclear. In new HD zoom endoscope, the whole image is bright, so we can find other regions. And the mucosal irregularity is clearly shown. And the border and the area of the region is also identified. So we can determine that is neoplastic regions, gastric cancer. Here are the comparative images of the same regions examined by the two scopes. In the new HD zoom scope, the mucosal irregularity is clearly shown, and the border and the area of the regions is also can be identified. In conventional SD zoom scope, of course, the irregularity is identified, but the border and the area of the region is unclear. Here is the case of the early gastric cancer regions. In new HD zoom scope, the reddish color and the depressed shape is clearly shown. And because of the changing, because the irregularity of the intestinal metaplasia is also identified in the surrounding mucosa. In conventional SD zoom scopes, of course, the region is identified, but the depressed shape is unclear. And the change in the mucosal irregularity of the intestinal metaplasia is unclear because of the rough and the low resolution of the endoscopy image qualities. So I showed the several gastric cancer cases. The new HD zoom scope provide bright and clear images. So this new scope may improve the diagnosis abilities for early gastric cancers compared to the conventional SD scopes. So we evaluate the difference of the diagnosis abilities between the two scopes. That means that we evaluate which endoscope has higher diagnosis ability for early gastric cancer. To evaluate it, we made a questionnaire, like a quiz, to identify the location of the gastric cancers in endoscopic images. We collected 60 endoscopic images with or without gastric cancers examined by both UHD and the conventional SD and stream endoscopes. All collected endoscopic images were divided into 9 sections using line and endoscopist institutions. My colleagues answered and identified which section had gastric regions. And finally, we compared the diagnostic ability of the accuracy, sensitivity, and specificity, and more between the UHD and the conventional SD stream scopes. In the result, the diagnostic ability of the accuracy, sensitivity, and the negative predictive value was significantly higher in UHD stream scope than conventional SD scopes. In our analysis, the AOC value of the new HD stream scope was so high as 0.89, which is significantly higher than the conventional SD scopes. Here, the subgroup analysis of the diagnostic ability between the two scopes according to the endoscopist levels. In this subgroup analysis, the sensitivity and negative predictive value was significantly higher in UHD stream scopes in both expert and trainees. So that means the new HD stream scope may provide the higher diagnostic abilities for all endoscopists regardless of the endoscopy level. In addition, the sensitivity is the most important indicator for the screening. So the new HD stream scope may be the better tool for the screening EGD comparing to the standard definition SD conventional stream scopes. So we concluded that the new HD stream endoscope may have higher diagnostic performance for early gastric cancers with bright and clear image qualities. Here, the take-home message of my presentation. The new GIF 1200N has HD quality and brighter images, even with the ultrasound size. So the scope provides a higher diagnostic ability for early gastric cancer, regardless of the physician's level. With advantage of the ultrasound size, the scope can be the best tool for the screening EGD. Both patient and physicians can be satisfied. That is all my presentations. Thank you for your kind attention.
Thank you very much, Suzuki Sensei. Your wonderful lecture. You emphasize the usefulness of importance of the high definition, and also he mentioned he talked about the basics as well. And I have a same question to Suzuki Sensei as well. So you recommend a transnasal approach or transoral approach?
Thank you for important questions. I think that this ultrasound endoscope is acceptable, suitable for both procedures. But just in my opinion, I preferred for using for par-oral endoscopies because the par-oral endoscope is more simple and with less preparations.
Yes. And the other times, par-oral approach, we can see inside mouth. So that's one of the advantages. Yeah. So thank you very much, Suzuki Sensei. And then, so we will move on to the discussion all together, Dobashi Sensei and Suzuki Sensei. So my first question is, so we totally recognize the usefulness of 1200N. So my question to two of you is, X1 processor has the capability of several image enhancement. So so you are both of you are talking about the NBI, but so this scope can have the function of other image enhanced technology.
Yes, this new scope 1200N can be used in X1 processor and the prior Lucero average systems.
Mhm.
But I prefer using the scope with the X1 processor because Dr. Dobashi mentioned the new IAS system, the BIMAC. BIMAC can be used with this new scope, and I think that is the very best combination. The BIMAC enhance the distant part to the making the more bright. So for brighting images is so important for the screening and EGDs. So I think the BIMAC with 1200N is the best combination for the screening.
Mm-hmm. So I have a question to Dobashi Sensei. We totally understand the 1200N. It's a very high resolution, and the NBI works very well using this scope. So my question is, can we apply TXI imaging to this endoscope?
Yes, I have experience of using the TXI system both in the esophagus and the stomach. However, the NBI is powerful for the esophageal cancer. So I think the TXI can improve the detection rate of esophageal cancer compared to white light imaging. However, I think the NBI is best for the esophageal cancer. On the other hand, in the stomach, there is a chance to improve the detection rate of the stomach gastric cancer compared to white light imaging, because the TXI can enhance the structure and color. And there is a report of the LCI from the Fujifilm. So the data says the improvement of the detection rate compared to the white light imaging. However, the combination of the NBI and the endoscopy new system is very good. So we can observe the whole stomach, and even with the NBI. So I'm very interested in the power, the detection rate of the NBI and TXI in the future.
Okay, thank you very much. I would like to ask the next question. I totally understand the usefulness of this new scope. Myself use it, and it's simply I feel it's a bright than a conventional scope, and of course a high definition. So both of you talked about. And my question is, everything improved in the scope, but do you point out some more improvement in this equipment?
In my opinion, I hope the improvement for the suctioning size, the accessory channel size. Yeah, accessory channel size is the same to the conventional scopes as 2.2 millimeters. So the suction ability is limited, and almost the devices, interventional devices, cannot be used. So if the size is larger, 2.4 or 2.8, that's the perfect endoscopy for screening and some procedures.
Okay, I understand. So working channel is the 2.0 in this scope. So
2.2, yeah, 2.2.
2.2. So yes. Still, sometimes you feel the not sufficient of the suction function.
Yes, that's right.
Other purposes, this is of course this scope mostly applied to screening endoscopy. So biopsy channel is a 2.2 is okay. So now we have a 2.0 biopsy, small caliber biopsy. It works very well. Do you agree?
Yes, I agree with you that only the pediatrics, very small biopsies forceps actually can be used, but I think that is enough for in the clinical settings for the screening.
Okay, so anyway, so Suzuki Sensei point out suction channel, that is a working channel thing. So 2.2 working current working channel. In the future, it can make it larger. So his opinion. So what do you think about the Dobashi Sensei?
I totally agree with Dr. Suzuki. There is another company around the transnasal endoscopy that mounted at 2.4 millimeters. So it's quite different between 2.2 and 2.4. It's a little bit, yeah. I feel the difference. So it's very important to.
The difference of the suction function.
Yeah, that's right.
So particularly when you sack the liquid.
And also the washing the stomach is very important to high quality endoscopy. So it's really challenging to washing out the yes, washing and suction.
Okay, so when you flush the lumen with the syringe at the time, so you feel not a 2.2, so 2.4 is much better.
Much better, yes.
So
I feel that.
do we need a 2.8 channel?
Is it possible to mount such kind of larger channel? I don't know, but if you mount the larger, yes, it's best, I think.
Okay. So thank you very much. So next question is we'll be talking about the future. I would like talk about it. So regarding GI screening, upper GI mostly, upper GI screening, this scope will replace the current used standard scope that has the 2.8 channel and the outer diameter of approximately 9 millimeter. So do you think this scope will replace it?
Yes, I think so. This endoscope can become the best choice for the screening system. And I recommend this scope should be used with the EVIS-X1 new system because it's brighter NBI and brighter reduction of the noise. Yes, it's the best combination right now.
So yes, so both of you in the point of a diagnostic capability, diagnostic ability of this scope, this scope will replace the current large diameter, large I mean 9 and more. So current available screening endoscopy. Is that right?
Yes, so for the screening and the performing the diagnosis, the scope definitely can be changed, can be replaced to the standard of scopes.
Okay, thank you so much. So everybody recognize the usefulness of the scope or screen. And do you have any comments more? No, it's okay. So time runs very fast, and I really appreciate two distinguished speakers. I hope audience enjoy the beautiful image and the discussion. So thank you very much.
Thank you very much.
Thank you very much.